Mr. Chairman, fellow speakers, ladies and gentlemen, it's an honour and a privilege to be invited to speak at the patient conference. And just before I start my talk, we are really lucky in the PH community to have such an active and progressive patient body. And on your behalf, I just want to sort of make a bit of a vote of thanks to Ian, Helen, Sean and the team that make all this showpiece event happen, but also work tirelessly for all of your benefit and ours throughout the year. So thank you, Ian. Yeah, that's right. So I was given the challenge of trying to make some predictions for pharmaceutical management for pulmonary hypertension over the coming few years. And as I started to think about my talk, it did, as an armchair sports fan, strike me a bit like pharmacy punditry, and we come back to this sporting analogy. But recent times perhaps suggested to me that being a pundit wasn't always quite so straightforward, and not many pundits predicted that Leicester would win the Premiership, and perhaps that Tyson Fury would become a boxing heavyweight champion of the world. But I'll do my best. So I'm going to present to you my first team lineup for pulmonary hypertension treatments for the coming year. And we start in goal with the surgical options of transplant and pulmonary endarterectomy. I put them here because they're a backstop. They're the last line of defence where other medical treatments maybe have failed or are ineffective. But sadly, there are still too many occasions when even our goalie doesn't have time to keep the ball out. Our central defensive partnership are diuretics and anticoagulation, two old hands, and the experience that they have really underpins all the other treatments that we use in our clinic for virtually everybody. At fullback, I've selected oxygen therapy and exercise and physio. I'm expecting these options to give the side energy, dynamism, getting down the flanks, and hopefully they can combine increasingly effectively. They will support the other medical therapies that are on offer and give time for other treatments to take effect. And over the coming 5 years, I'm really expecting physio, particularly, and exercise programs to take off and be a really valuable part of our game management. Central midfield, there's only one option here, the phosphodiesterase type 5 inhibitor, so sildenafil, tadalafil, PDE5s. Since bursting onto the scene 10 years ago, these agents form an integral part of about 90% of Sheffield's patients' therapies. Almost universally tolerated, effective, and since they came off patent and went to generic, they're about the closest thing we've got to free transfers. Alongside PDE5s in midfield, I've selected some other oral treatments. So firstly, the endothelin receptor antagonists, bosentan, ambrisentan, macitentan, the ERAs. They're subject to intense scrutiny in terms of monthly drug testing, but can be hugely effective in the right setting. The ERAs have been really proven over the long term, treating disease and improving outcomes. And crucially for the team, the evidence of how well they combine in the midfield with the PDE5s is without any doubt. On the right wing, I've selected a first-team debutant, Selexipag. It's been proven in the world's largest ever trial program, and I believe absolutely worthy of a first-team place. Working in combination with the other midfielders will be an invaluable alternative to complex prostanoids, potentially making a difference in some currently unwinnable situations. Convincing the NHS of its value and a place on the team is proving a bit more tricky, sadly. At number 9, are the parenteral prostanoids, our centre forward, the go-to option when we really need to take the fight to the opposition. Potent, fast, effective, ultimate striker. Supporting it in the attack, I've got 2 treatment options that I can see being called upon in difficult situations which require a bit more of a niche approach. Firstly, denervation, the first non-surgical intervention ever to show benefit in pulmonary hypertension, Animal studies from colleagues of ours in Sheffield and some early work from a group in China show that it may be potentially worthwhile in certain forms of pulmonary hypertension where medical therapies are less beneficial. Ria Sigwak completes my first 11, more of a specialist player requiring a specific type of game to demonstrate the benefit, but definitely worth a place on the team sheet. Beyond the first team, I've got evidence here of how far pulmonary hypertension has come in a relatively short time, with some strength in depth. My subs bench is a good blend of youth and experience, with emerging talent and some old stalwarts, all capable of potentially doing a job when called upon. VADs, ventricular assist devices. This is an implanted device which may help a struggling heart. Not utilised in Sheffield up to now, but potential for the future. Imatinib seems to be very effective in the setting of severe disease, but fails to make my first team on account of all the side effects and hence the potential to injure opponents en route to goal. 30 years since being unearthed in America by a physician called Stuart Rich, calcium channel blockers continue to make an impact given favourable conditions. And finally, some players emerging from the academy. Tacrolimus, currently on trial in pulmonary hypertension, but already proven to be safe and effective in other clinical areas. And biologics, anakinra, etanercept, tocilizumab, look most likely to come through and make it, but yet to be really unproven. And as other well-known TV pundits will have found out, it's a lot easier to comment from the studio than to do it for real. So getting your tactics and strategy right is down to effective team management. I'm sure the other clinicians here today might have set out their team differently, and we can debate all night about the ideal setup. But rather like the beautiful game, each patient is different. They require their own approach. Over time, increasing use of different combinations and likely people being on 3 or more treatments should become increasingly common. We need to learn from our data, from registries, genetics, biobanks, and evolve our tactics. And I'm certain that we would want to avoid the sort of haphazard approach that you see here. And over the next few years, I'm sure we'll get closer to that. But right now, conferences such as this one give us the opportunity to reflect and analyse progress and plan future developments. Analysis at this stage is vital, as it is just to every TV pundit. And as I draw my predictions to a close, I'm going to paraphrase the nation's favourite football presenter Gary Lineker's famous quote, showing that perhaps even the best don't always get it right. And I thank you for your time.
Some of us heard Neil present that at a conference about 18 months ago, a professional conference. It was quite remarkable. I think one of the things that it shows there, we're going to touch on one or two of the drugs in the reserve, like the issue with a drug called, in this case, we'll be selected by in the question time, because I know it comes up in some of the challenges that we have as a clinical service, but also as an organisation like here. And Neil's sort of, I suppose, reserve bench of future developments that you may or may not be aware of this news item. It's not false news. The NHS has got a few problems. One of the things that we as an organisation and yourselves together collaboratively, and I'm going to talk about this in my talk as well, is that the one thing that we will make sure is that they do not try and disinvest in this disease area. And we can only do that together with a common understanding. So we will touch upon those sorts of things. So there's much about the future as the past that's really important here. And the analogies, I don't make any apologies for people using these analogies, because the one thing that's really important, we've got really clever data in PH, really expert clinicians in PH, but sadly sometimes the people making really important decisions do not understand science and data. So what we have to do as a group and an individual collaboratively is work together and tell the impact and the lived experience. And that's some of the stuff that we've been talking about. So thanks, Neil. I know you're on the expert panel later. We'll touch on one or two of those things there.